Major funding for end-of-life decisions and NPT Reports Town Hall is provided by HealthSpring, lead sponsor of NPT's Senior Health Project. HealthSpring, where you get more from Medicare and more from life. The West End Home Foundation, supporting the care of seniors through many organizations in Middle Tennessee. By the Jeanette Travis Foundation, dedicated to improving the health and well-being of the Middle Tennessee community. The Corporation for Public Broadcasting, and by members of NPT. Thank you.
Hello, I'm LaTanya Turner. Since they were born, members of the baby boomer generation have played a big role in shaping American culture. In 2011, the first of the boomers turned 65. As they age, the sheer number of people entering their senior years will undoubtedly have an impact on how our communities understand and respond to the needs of older citizens. By the year 2020, Tennessee's population of people over age 65 is expected to grow by 36%. In response to this new reality, Nashville Public Television is launching a series of programs addressing issues of aging in Middle Tennessee. We will look at the strengths of our community, as well as the challenges facing older citizens, their families, caregivers, and the institutions that serve their needs. We will also explore what is being done to make sure we can meet the needs of this booming generation. Today, we kick off this project with a town hall meeting on end-of-life decisions. We invited doctors, chaplains, caregivers, hospice workers, and community members to share their experiences and perspectives on what our community gets right and what it gets wrong when dealing with people in the last years or months of their lives. Join us as we learn together what our options are and how we can be better prepared for a part of life we will all face.
This program is produced in partnership with Alive Hospice and the Gift Initiative of Alive Hospice, funded by Humana.
Hello, everybody. I'm LaTanya Turner. Thanks for being with us. I'm going to be guiding our conversation today as we talk about end-of-life decisions. How do you want your end of life, your final days to look? Where do you want to be? Who do you want to be with you? How do you want to feel at the end of life? Yes.
I'm Ruth Garrett. Yes. I'm a retired gerontologist, and I want to stay at home. I want to age in place at home at the end of my life.
Okay. How many people want that? Okay, not quite as many hands, so obviously some of you have some other thoughts. Anybody have a different thought about where you'd like to be at the... Yes, sir.
When I think about that question, it really relates to what the circumstances are, because that's an easy one that you'd expect 99% of everyone to answer. But I don't want to be a burden on the family. I want it to be smooth and comfortable. And for the my parents and my wife's parents, we've all lost all of them over a period of 10 years. Each one, there was a different answer for each one of them. It depends on the circumstances.
All right. Well, we actually did a survey, as some of you know. We surveyed you, we surveyed some other people and asked them this question. We asked, when you think about the end of your life, where would you prefer to spend your last days? And we had several options. The three choices were home, hospital, and nursing home. Home, by far, was the biggest response. In fact, 100% of the people we polled said they would prefer to die at home. Yes, would you like to share your thoughts with us?
My thought on it is I wouldn't want to be a burden to my family, and I would think I would be if I was in a critical situation. Although I would love to be at home, I wouldn't put that demand on them because that's hard to live up to. It is especially depending on what condition I would be in. And if I was in a critical, needing 24 hours of care, I would definitely want to be in a care facility.
All right, all right. Well, several of you have mentioned that you don't want to be a burden on your family. So let's talk about some of the decisions that shape your preferences about end of life. We also did a survey asking that question, the factors that are involved in your decisions, and we asked people to rank them in order of priority. So priorities for end-of-life care decisions at the very top is quality of life. Next is freedom from pain. Third is not to be a burden on your family and loved ones. Next is financial cost. And the last choice is live as long as possible, being a priority. Thank you all for sharing your thoughts about that. We've kind of set some examples of what we all want at the end of our lives, what we think is a good death. But do we get what we want? Well, we took a closer look at that, and we have a video we want to show you right now. Most Americans say they would prefer to die at home, but for the majority, that's not what happens.
When he first entered into the hospital, it didn't seem like this was going to be the end. We had gone through bouts before, like it didn't seem any different than the other times.
Jackie and Elisa's father had been diagnosed with prostate cancer 18 years earlier. Later in his life, he also struggled with diabetes and a heart condition. When their father went to the hospital for the last time, they didn't know what illness was causing the problem.
We didn't realize how serious the situation it was, and I don't think anybody ever told us it was a serious situation. You would think after being through cancer and treatments all this time, we'd be more prepared for a death. Emotionally, but it wasn't, because we had gone through it so many times and he had come out fine.
I think people they say they would like to die at home, but when it becomes reality, they want to see if there's something that can be done. They don't know what to do, and so they bring them into the emergency room.
Once a family calls 911 or shows up in the ER, the healthcare system takes over. Nearly a quarter of all American deaths occur in an intensive care unit. Today, many ICU admissions involve individuals over the age of 65 living with a chronic illness. Those admissions are the most likely to receive end-of-life care in the ICU setting.
We're really trying to focus on acute care issues that we can fix. Sometimes we can intervene and extend somebody's life. I mean, we have great resources in medicine, and using those appropriately and trying to get someone through that acute process so that they can have some more time with family and friends. I think that is a good thing, and we do that on every day. It's sometimes trying to use those resources in ways that we know we're going to be futile. That is difficult.
You're there at the hospital where you know that he's going to get cared for. But when you're there and you see that he's in pain, or you see that, he's in trouble or something, and you can't do anything about it, or you feel like you're not being listened to, it's stressful. You're on an island by yourself. Right. Definitely.
3/4 of individuals over the age of 65 visit the emergency room during the last 6 months of their lives. Even when death is expected, half will enter an emergency room in their last month of life. Everyone will eventually reach a point where treatment is no longer possible.
It's not uncommon that a family has unrealistic expectations regarding what the medical community is able to provide, whether it be an acute illness or a chronic illness such as cancer. And it is our responsibility to say to them, medically, ethically, this is what we have, this is our resources, this is what we can do within our limits.
I don't want to die in an ICU. I wouldn't want anybody to die in an ICU. But in those acute situations where you have a good chance of a quality of life afterwards, I think that is a good place for an ICU, a good place for a patient. If I wouldn't have a good quality of life afterwards, I wouldn't want to have a prolonged dying process.
So clearly there's a discrepancy or disparity between what we want, what you've even said today that you want at the end of your life, and what most people wind up experiencing, right? So why do you think it is we don't get what we say we want at the end of our lives? Yes.
Hello, my name is Shari Beauregard. I'm a nurse practitioner at Baptist with Palliative Care, and decisions regarding end of life should not be discussed at the end of life. It's analogous to talking about or trying to prepare a mode of escape when the house is already on fire. You're confused. You don't know what to do. You're running around and you're scared. So we should not have these expectations that families and patients can make these decisions during the hardest time of their lives. So we don't discuss it during the last 6 months of their life. We discuss it when they're first diagnosed, because we know some of the trajectories of illnesses. We know that there's no cure for COPD or congestive heart failure. We know the trajectory. So why not have those discussions initially? So
and
that
who should have those discussions?
you should have those the diagnosing provider, the primary care provider.
How many of you have those discussions if you have a diagnosis that has, anybody want to share how you go about it? Yes, sir.
I'm Larry Churchill, work at Vanderbilt. I think the most important part of the conversation actually occurs between families. And the GIFT initiative was precisely around that. The GIFT was the conversation you would have with the members of your family, so there wouldn't be second guessing, so people would be clear. And I think this is the single most important responsibility around this whole area, which is how do those of us who are reaching an older age converse with our children, our adult children, and how do they converse with us around that?
Okay. I think a lot of us do talk to our families, though, and say, oh, you know, here's what I want in the end. You know, or grandma always said she wanted this in the end. But many people don't know where they are in the progression. Wouldn't you agree? I mean, that certainly seemed to be the case with the family we just heard. So is it, you know, the family's responsibility to know where they are in the progression of life, the timeline toward the end of their lives? Anybody want to comment on that? Yes, sir, Dr. Goldman.
I'm Bob Goldman. Spent a couple of decades being an ICU doctor and went back to school and did a fellowship in hospice and palliative care. The conversation needs to be at a coffee table on a cool, calm, quiet night. It doesn't need to be in an emergency room. It doesn't need to be at someone's funeral. The fact of the matter is the things we have in common is the end of our life. And to not take the responsibility is one of the things that I used to see on a regular basis as a huge source of suffering for families and for patients.
Whose responsibility? Who is not taking
all of our responsibilities.
Oh, everyone.
The dialogue has to be out there. This is the elephant in the room that no one wants to talk about. That, you know, grandma's getting worse, you know, she's getting slower, dad's not remembering quite as well. Before dad loses more of his faculties, maybe that conversation should happen perhaps a year or 2 or 3 before things are at a point where everyone's going, oh my goodness, now what do we do?
And that's what we're I think Sherry mentioned. It should start sooner, but no one is going to start when the person's still walking around looking pretty able and capable.
We have standards that we all want for ourselves. I'm perfectly happy to advertise that my advance directive is done, and I have no intentions of using it anytime soon. But I could.
Okay. Yes.
I'm John Surgeon, and I'm a physician at Vanderbilt. I would also like to say that I'm afraid the medical profession itself is culpable here. We have not done a very good job of being honest, and in part it's because we tend to be optimistic. We may know the statistics that 60% of people with heart failure at a certain level are going to be dead within a year, but not this patient. This patient I care so much about. This person's going to do okay. And it makes it more difficult to have these conversations. I do think that the palliative care initiatives that are going on in American medical schools today are beginning to change that and help us be more honest with patients, but it's been a problem.
Okay. So what kind of care, I mean, you touched on a topic that we want to address. Is the medical system set up to provide this part of care for patients? I see you shaking your head, Dr. Goldman. We're going to give you the floor again.
We're in a fix-it mode. We come to the hospital to get better. The expectation is we're going to get care. We're going to get all the care that there could possibly be that will extend our lives. But the reality of the situation is, and I'm not going to take credit for this one, is that the day that a COPDer dies looks just like that day last week. We can't predict these things, and frankly, we don't get paid to say no. We get paid to say, yes, we'll try. Yes, we'll do this. Yes, we'll start dialysis. Yes, we'll try a respirator. But in point of fact, the data that's out there is scary as to how bad we are at really being able to prognosticate short term, when is it really that time?
Okay. Lots of hands here. Let's go over this side for the next response.
I'm Denise Salper, and I work with Alive Hospice. One of the comments that was in the film said there comes a point where treatment is no longer possible. But that's certainly has not been my experience. Like with my father's illness, there was always one more thing. There was never a discussion about what I've come to learn is the gold standard of care, which is hospice. So in terms of the system, I mean, there's just a cascade of events, new specialists, up to 10 physicians in the last couple of months of life. And so the system was very confusing to us.
Okay. Let's go here first.
Jim Schulman with the Tennessee Commission on Aging and Disability. Do we still try to fix everything? I mean, I think that's what we were talking about, or have we changed that? Because I know in a personal situation, if I were, and this gets back to knowing whether you signed all the documents or not, but if I go to a facility or somebody sends me to a facility, maybe I don't want everything fixed. If I've got all the documentation taken care of, maybe somebody sends me there, but maybe I don't want everything fixed. Maybe it's my time. And how do I make sure that wherever I go, they don't try to fix me, that they let me go the way I want to?
Yes.
I'm a primary care physician as well as a palliative care physician, and I think what we're all talking around is sort of the buzzwords in palliative care is goals of care. You go to a hospital and if you have heart failure, they try to get fluid off and you feel better. If you have COPD, we want you to stop wheezing and your oxygen requirement to go down so you feel better. But what we're all talking about but haven't actually named is, what do you really want? What is your goal? Are you hoping to make it to your son's graduation? Are you looking to celebrate your 50th anniversary? Or are you just trying to squeeze out every last drop of life? And all of those things are okay, but we don't have those conversations in the hospital very often. And in academic institutions, as you round, you see the patient and they're better from the state they were, because hopefully what you're doing is helping. And the medical student may say, well, Dr. So-and-so, are they really going to do okay? You said they're doing so well. And we may say under our breath, well, they're doing better, but their likelihood of survival over the next several years is very low. In fact, I don't think they're going to be alive next year. But that conversation, in the way our system is set up, hasn't gone back and trickled down to the patient. So we're having patients and families make decisions in a silo without the appropriate information they need. If you could say to a patient, it's Christmas right now, and I worry you're not going to be here next year. And I don't have to be right and I don't have to be wrong, but you need to be able to put that out there, and then all of a sudden the choices we're making are very different. I think that's the gap in the healthcare system. Everyone's doing it for the right reasons. I don't believe there are malicious people out there and we're all at it for money, but I think we're all looking at it at different angles, and sometimes we have to rephrase that question.
Thank you very much. And that really is a good transition for us to talk about some of the choices and how you get to those choices that can preclude you from having a death that's not the kind of death you want. We have a video that we want to show you, and then we'll talk some more about this. Hospitals may have been built for acute treatment and cure, but Dr. Mahana Karlekar has a different goal in mind. Dr. Karlekar is the director for palliative care at Vanderbilt University Medical Center.
I met you on Friday.
Instead of curing patients of their illness or repairing a part of the body, her priority is quality of life for both patients and their families.
Palliative care is a very new field. When I was a resident in training in the late 90s, it didn't exist.
Palliative care focuses on providing patients with relief from the symptoms, pain, and stress of a serious illness, whatever the diagnosis. It can be provided alongside care aimed at treatment and cure, but the point of palliative care is to treat the whole person, not just an organ or a particular disease. Part of palliative care is also helping patients understand what treatment options are available.
The most common specific illnesses we see in the geriatric population would be diabetes, emphysema, chronic lung disease, chronic bronchitis, heart failure, and cancers. I think when we look at folks, it is so important to be able to talk to folks about what their symptom or their new complication is and how it relates to who they are. That's what patients rely on us to do, and if we don't give them that information, they can't make wise choices.
I've got to keep my spirits up, you know.
When I meet people, I'll say, your physician called me in, I'm the palliative care physician, I work with a team of docs, nurses, social workers, chaplains. Our goal is to do one of the following. We help out with symptoms, we help people to develop what's called goals of care, trying to come up with a plan for you that's medically realistic and that's based on your values. And finally, we're the physicians who refer to hospice.
Hospice is a form of palliative care provided when there is no option for cure and death can be expected within 6 months. Hospice care is usually provided in the home, but hospice residence facilities also provide care.
One of the really concerns that people have about hospice care is that it means that all treatment is going to be foregone. I'll just kind of be let go. And I think that's really completely not true. The focus is on treatments that are aimed at providing comfort, relieving suffering. They don't do treatments that are aimed at extending life. But what you often see is that when you provide this kind of coordinated care, you bring treatments, you simplify treatment, you give treatment that is aimed at providing comfort, people may survive longer than you would expect, longer than you would have anticipated.
When my mother was referred to hospice, I knew the time was getting close. She was actually more debilitated than I had realized. We really needed a 24/7 nurse. We didn't have the resources for that. Mother was very sick. The folks at hospice, they tried to accommodate Mother. There was a lot of comfort knowing when I was at work that Mom was receiving excellent health care. And not just the health care, but that they were being kind to her. She responded really well to someone being kind to her and listening to her and explaining things to her, not just coming in to do a procedure, just the little things. It's the little things that stick out in my mind.
There are nice studies in the literature that show when you introduce palliative care early, people don't die faster. They utilize services better. There was a lung cancer study done by Tamel, and what that looked at is stage 4 lung cancer patients who were given either palliative care, which is seeing a doc like me. They got 1 to 2 visits tops, or just getting standard care, which was seeing your oncologist and getting your treatment. Patients lived about 60 days longer in the palliative care group. I'm not arguing that we make people live longer. Maybe we do, but we're certainly not making people live shorter. And if you can make people feel better, have a better understanding of their illness, why wouldn't you do it?
I want to talk some more about palliative care and hospice, making sure that people understand what it is, sort of where one begins, the other picks up. Dr. Carlikar, is that something you'd be comfortable kind of helping us to understand a little bit more about palliative care and hospice care and how they correlate?
So palliative care is, if you can imagine, a very large umbrella, and it's taking care of patients with a serious illness. It doesn't necessarily mean that you have a terminal or life-threatening illness, and it's taking care of that patient in a multidisciplinary approach. So with physicians, nurses, social workers, chaplains, music therapists, if you can get them, every discipline that you can bring to the table to be able to take care of that patient, knowing that not one single person or one single discipline can figure it all out. And the role of palliative care may be large or small depending upon the need. If you have a diagnosis of colon cancer and it's a brand new diagnosis and it's not terminal, but maybe we're not sure how someone's going to do because they're older, and the chemotherapy is going to create a whole lot of symptoms, that palliative care specialist may be instrumental in trying to help that person through the nausea, the vomiting, and the diarrhea to get their symptoms managed. Well, maybe over the next several months they're doing just fine. Maybe they don't need as much of the palliative care specialist, the oncologist, as that person, but you have a tag team approach where it goes along in parallel, as opposed to the prior model where sort of palliative care was right at the end. Hospice is similar to palliative care in that it is providing multidisciplinary care for a patient and their family. Again, these are patient and family-centered approaches. The difference is that you have a prognostic statement part of that. So we have to, as medical professionals, say that someone has, with our best medical judgment, based on the natural course of that disease, someone has less than 6 months to live.
Dr. Schuster, can you pick up with that and tell us how hospice works?
Well, I really view hospice and palliative care as really all of a piece. And the distinctions are largely artificial because of the way that hospice is funded. And so the regulations about hospice care really have to do with the prognostic statement that Dr. Carla Carr talked about. And that's the way that the regulations, particularly through Medicare, sort of require that for someone to receive the hospice benefit from Medicare, that there's this prognostic estimation of 6 months or less of survival. It doesn't mean that folks who are on hospice won't outlive that prognostic estimation. But I think the kinds of care that are provided, where you're coordinating care, you're bringing a team of folks from different specialty areas and different disciplines in healthcare, is really very similar. And so what palliative care is essentially doing is taking a lot of what we have learned over the years about the best part of hospice care and just moving it upstream. I don't expect that we'll be living with the same set of regulations for years and years to come, and I really expect that the distinction between what's clearly hospice care and what's clearly palliative care may be less distinct and more blurred. It may be more obviously all of a piece as years come.
Okay. Shari, why don't you tell us how you kind of invoke yourself into a scenario with a family, a patient, as a palliative care specialist?
A lot of times when I go in to see a patient and their family, they're very scared. Most of the time, though, we see them in the late stages, so it's more towards their end of life, which is unfortunate because we could help them so much sooner. But because we do see them a little bit later, we talk about what their thoughts are about their diagnosis, what they've been told about their diagnosis and maybe their prognosis. And a lot of times patients are fearful, their family don't understand. And so it makes it a very difficult conversation. Like I said earlier, it's hard to have those discussions when it's, that time at the end of life. But we try to manage patients and help the physicians figure out how do we keep them comfortable and what we can do. But some of the problems I see is that when patients have made decisions about the end of life and what they want, sometimes when they get into the realm of their disease where maybe they're not very alert and oriented, and that person and their family making the decisions for them decide to go against what they initially said they wanted to do. Because they're fearful. Their emotions take over. So I think that a big question is, how do we empower the providers, some providers that kind of say, okay, whatever you want us to do, because we don't want a problem with the family. We still have to empower ourselves, our physicians, our providers, to say, there are some things that are not appropriate to do. So,
is it an issue of empowerment or is it a problem of acceptance?
And maybe it's both.
Okay.
I think it's both.
Yes.
Hi, I'm Dr. Chip Chambers. I'm the Senior Medical Director for HealthSpring, and I'm also on the clinical faculty at Vanderbilt at the VA. And I think I'm a surgeon, so it's a sort of unique medical perspective. But in my role in the business side of healthcare, about educating and talking with physicians, I think what you've really hit on is key here. I think even within the physician community, physicians do not understand what palliative medicine entails or what it involves. If I get consulted by one of these physicians in the room, it's very clear. I'm a surgeon, so there's a surgical problem and we need a specialist. While we can educate the physicians to understand it, to me it's more of an issue of educating them to call on these specialists who, as you saw in that video, have a great gift for doing this.
Okay.
Not, even though, as Dr. Sargent mentioned, we're beginning to train physicians to do this, many of us who have been out have not been trained to do this. So here we have this group of unique specialists who are gifted and can have these conversations really better than I can have them as a surgeon.
Yes.
Hi, my name is Ann Nguyen, and I actually do palliative medicine. But as a primary physician, I think the larger issue is that as an American culture, we don't accept death as part of the living process. So it's nice to have families talk about these goals of care, but when they go to their doctor, this is the push and pull that we get. It's like, well, are you sure you don't want the surgery? Are you sure you don't want dialysis? So I think, again, on piggybacking on what people were saying, is that as clinicians and as expert providers, whether it be physicians, NPs, or whomever in this field, we really need to start to accept the fact that people die. It's unfair. It's part of life. But again, preparing for that. So the dying process could be hours, but it actually can be months, weeks, and go out a little longer. So the question is, how do we help our society, whether it be the healthcare physicians, understand and work together to know that it's not an exclusive, meaning that we're not giving up. We actually are doing things. Because when I was in residency, they told me, you do not let anybody die in your watch. And so it's ingrained in who we are as physicians, because we do like to fix things. So now we're changing the mentality, is that how do we care for the disease, but also care for the quality of life of our patients. So again, as a primary physician, we didn't want to talk about death. Oh, no, you're not going to die. We have all these medical resources. But as we know that that's not the case, we need to figure out how to have a conversation on a larger scale.
Yes.
I'm Yolanda Holmes, and I'm a nurse practitioner at Baptist as well in palliative care. One of my fondest memories growing up as a little girl was when my grandmother died. Not the death, but she came back to her home, and she lay and stayed in her home. And it was so much fun to me as a little girl to see all of the family and all of the friends and all of the celebration. That's my greatest memory of death. Where has that been lost? Mm-hmm. Where is that lost? I think that's part of the problem, is that we don't see death as a part of celebration. We enjoy birth, we celebrate, we gather around, but we've lost the death. Mm-hmm. Our society does not celebrate the death.
Or even accept that it's happening.
Or even accept that it's going to happen. And I think the first thing we have to do is get back to when our great-great-grandparents died. It was a celebration of a life lived. Mm-hmm. People cannot accept where they are because we cannot accept that one fact. Okay. Really important.
Yes.
I'm Gretchen Gagan with LifeLink's Geriatric Care Management, so we help families make these decisions and walk through the process. And I think we're talking a lot about physicians and their responsibility to educate the families and the patients, but we often see that denial is so strong that we don't want to talk about it. And even when the physicians and the other professionals are being very clear to say, this is the body shutting down. This is what is happening that's letting us know we are close to the end of life. It's just really hard for people to get past that. So I don't think it's one conversation as well as that one conversation can be. It really has to be an ongoing process with every medical professional that they come in contact with and with the clergy, so that eventually it becomes something that we're comfortable with and we can make the decisions to have control over that end process.
You know, oftentimes, though, you hear families like Jackie and Elisa in the first report saying that, you know, we weren't sure what was happening. You know, they seemed informed and aware of what their father and their mother would want, but they weren't quite getting direct information. And from what I've observed, when you get to the hospital, you're not necessarily with someone that you have a relationship with. The primary care doctor is probably no longer involved. You may be seeing a hospitalist. Who's supposed to have that conversation, and how do you help that family understand, again, the trajectory before it gets to the end, so they know, oh, okay, if there's trouble breathing, this is one phase of the process. Yes, sir.
My name is James Vander. I'm involved in ministry in a faith-based resource center on aging. It seems to me that if we're not careful, this is getting to be a little one-dimensional. We're only talking about medical diagnosis and the trajectory of what that might lead to in terms of decision-making. We are whole beings, and we are more than just a physical body. And these conversations need to be much broader than a diagnosis. They need to reflect our belief system, our values, to your point, our family and our family structure. And it would seem to me that the conversations that we're alluding to need to take place well before we're sitting down to talk about a diagnosis.
And I think you're right. How do you incorporate that in your ministry? Because not a lot of ministries, I think, are tackling it head on. It sounds like you are.
You are correct. We are not. To Gretchen's point, many times this is not represented at the table where that discussion is taking place. Even the discussion becomes one-dimensional. The aspect of the faith community is not present. But I think also it begins at a time when we are evaluating the broader ethics of life. What do I consider to be not only good death, what do I consider to be good life? Because that might well affect how I would define good death.
And you hear people talk about their faith walk if they are religious, and is that part of the process that often doesn't get addressed?
Absolutely, and that's our fault. But what we try to do is to address this with very young families. As maybe a marriage begins, what do you want from this marriage? How do you want your entire life to be lived out? And those kinds of conversations really empower the individuals who may at a later point in life be given that authority to act in one's behalf, to be a surrogate or to be the person who is designated on a document.
And how do you educate people that you're not acting as God if you make those choices?
It's a great question. Belief systems do vary. And it's interesting that some research certainly shows that people who profess very fundamentalist faith resist palliative care, resist the kinds of decisions that we're talking about because of the very thing that you've suggested, maybe that we are trying to interfere with life's normal processes. I think that gives clergy a tremendous opportunity to educate even that and to dispel some of those
What would you say to your
rumors.
congregant or a congregant who felt that way? Well, that's God's decision.
First of all, I think to presume to understand God's decision is a bit difficult on our part, a bit inappropriate on our part. Earlier, someone has said death is as much a part of life as anything. It may not be very pleasant, but it may be pleasant. I think we are making ourselves available to God's will by utilizing all that God provides for us. And that includes wonderful knowledge, wonderful medical care, all of those things. But it's a theological issue for some people. And perhaps in spite of all that we can do, we have to make them comfortable with whatever their belief system is, whether we agree with it or not.
Okay. Yes, sir.
I think we're talking in great depth about what caregivers can do, health professionals of various sort, clergy, people who work in this area can do. But I think it's also very, very important. I find myself, as I'm aging, I'm seeing this more and more and more as I'm not just the doctor, but I'm the patient. And I think more of what my needs are. So what I'm suggesting here is it's not just the doctor's job. I think we have got to educate patients and everyone to take the responsibility to bring these subjects up, to deal with them. And this is what the end-of-life decision, the GIFT initiative program has been doing, is trying to educate the people. You can't just educate the doctors. You can't just educate the doctors. We can't take all the responsibility. Patients have to.
And
also.
I think we all would agree that it's not just on the medical providers to be responsible for this, and I certainly hope that's not the message that's being conveyed. Yes, go ahead.
My name is Keith King. I'm with Alive Hospice of the GIFT Initiative. In my role in Alive Hospice, I do community outreach coordinator. So I think that there's a huge responsibility on educating from the medical perspective, from the medical field, and from all the professionals in here, educating the people that are going to be coming back into your offices one day. Also, kind of going back to the faith issue, something we started doing a couple of years ago was workshops on death, dying, and congregational care for the clergy, because there were some studies out of Duke and other places, and what we were realizing that people go to their churches, their mosques, their synagogues for whatever reason, but the ultimate goal is when I pass away, I'm going to go somewhere greater than this. But they don't ever want to pass away to get there. Everybody wants to get to heaven, but nobody wants to get on the bus. And so we're figuring out. So you go to these churches, and then I've had a few pastors that I've been trying to do workshops at their churches for years, and they'll call me every once in a blue moon and tell me, "Well, I'm not ready yet. Give us a couple months." Or I'll get to an event and I'm told there's going to be 90 people there. When I get there, everybody runs out the back door because they finally going to talk about hospice care. And so from 90 people, there's only 2. So with all that said, the conversations that we're having are great. They're growing, and I think people are doing a good job in meeting people where they need to be, but I think just more on the ground, whether you're educating people at their church, at the grocery store, if your palliative care practice wants to set up a booth next to the Girl Scouts while they're selling cookies and talk about that, I think that would help too, just meeting people where they are.
Okay. Some people find it easy to get to that point of those conversations and those decisions. Some people don't. How do we get there is an important question. We've touched on it. We want to show you a video now to get you to thinking about it some more, and we'll talk about it after the video.
As a social worker for Alive Hospice, working in a home team, I go into patients' homes and I meet with patients and their families.
Hi Jared, how are you today?
We help family members kind of understand the dying process. We try to facilitate communication if we can, so that it can be as good of a situation as it can be.
Anything about advanced directives?
Part of Teresa Quantz's job is to help families and patients think through the end-of-life care decisions they may face.
It's important to think about how you want the end to come and what you want done, or more specifically, what you might not want done. So we really try to help people do that.
One tool Quantz uses to encourage conversation is Tennessee's Advanced Care Plan, also known as a living will.
The advanced care form tells people your beliefs and your wishes about what kind of interventions you might want or not want at the end of life when you can't speak for yourself. And it gets pretty specific about what is quality of life for you and what interventions you want. Everybody's emotions come into play at the end of life, and it's really a gift that you can give to people by telling them verbally what you want at the end of your life, as well as writing it down and documenting.
Even without a formal document like a living will, talking about end-of-life decisions can make a difference when the time comes.
It was such a huge difference between what happened with our father and what happened with our mom. I remember specifically, she said, I never want to have a prolonged life where the quality of my life is if I can't take care of myself, I don't want to, prolong things. I don't want to do that. I don't want a long illness. And so we knew if we had to make that decision, what the decision would be. Didn't make it any easier, but we knew that she didn't want to suffer.
The conversations Jackie and Delisa had with their mom became crucially important. 6 months after losing their father, Jackie and Delisa's mother suffered a brain aneurysm, was rushed to the hospital and placed on life support. Family and friends came to her side. A decision had to be made.
I'm grateful for my mom telling us. By knowing what to do, it just made a stressful situation so much easier. We all talked about it, and it took us less than 5 minutes to decide what we were going to do. The family was all around. Everybody was in the room when it happened. We were a part of this whole closing experience that we felt at ease and at peace. It was just a huge difference, a huge difference.
I think the documents are primarily helpful as a stimulus to that conversation. Some of my family members have asked me to be their durable power of attorney healthcare decision maker, and I'm honored to do that for the people that I love. But every person who's asked me to do that for them, I have said, then you owe it to me to sit down and talk to me now. And let's go through some scenarios, and I want to be confident that I understand what you would want. If I'm going to serve this function for you someday, even possibly, then it's a loving thing for you to do to let me know what you would like for me to speak on your behalf. I need to know as much as I can about what you would want.
I have to ask, how many people here have an advance directive? Wow. Okay. Assuming that someone watching this wants to get started, wants to make sure that they have the right information about themselves or their loved ones, how do they approach it? In the green jacket.
Hello, my name is Dr. Gail Gazdag, and I'm not in palliative care, and I'm not a physician, but I have been trained in psychology. I just want to say from personal experience that my family was able to have a discussion with my father because my mother had died previously the year before. And because we saw how she died, my father was well aware of how he did not want to die. I was the caregiver at the time. I was very hesitant to have the conversation with him, and every night after dinner, I said to my husband, well, tonight might be the night. After dinner, we might have the conversation, but of course, I'd put it off. Finally, I got copies of all the advance directives needed, and I said, well, tonight is it. So after dinner, I had the papers, and I said, Dad, I have a conversation to talk with you about what kind of care you might want to have when it's time for you to go. And he said, I've been thinking about that. I wanted to have that conversation with you. I'm ready to have that conversation also because we saw what happened with your mother, and I don't want that to happen to me. And it was such a relief that that occurred that I wanted to suggest that sometimes when someone else has passed in a family, when you discuss that family member's death, that's an opportunity to discuss for the rest of us.
Just put it out there, I guess. Kind of is what you're saying, that maybe everybody else is waiting for someone to take the initiative. Yes.
Dr. Jim Powers, I recommend to my patients to look at the 5 wishes. Who do you want to make healthcare decisions when you can't? What kind of medical care do you want? How comfortable do you want to be? How do you want to be treated? And what do you want loved ones to know about you? When patients bring this kind of document to me, I'm impressed, and I put that in the medical record, and that tells me a lot about how to care for patients.
Okay.
I'm Reba McBride. I'm a social worker with Alive Hospice. And one of the things that I would like to mention too is we focused a lot on the forms. And one of the things about that is that those should be updated. It's not set in stone. It's not once you do it, it's good forever. It certainly can be, but it really should be updated. Your health changes over time. We begin life as young and healthy, and then, our health does decline. And so I do think that we need to constantly review that. We can make those changes to our advance directives, but more than anything, we need to be having that conversation with our family. We need to explain to them if things happen and this disease gets worse or that disease gets worse, this is where I would want to live and this is how I want my health care to be. I've had the great privilege of having this conversation with many families, and not everybody is in agreement. Not every family member understands the importance of it. And I think that that's a goal for all healthcare providers, is to make sure that we're talking to as many of the patients about how their family interprets what they want as well.
Has anyone just flat out had resistance and, family member patients like, I just don't want to deal with this? Yes.
Yeah, Larry Churchill at Vanderbilt. One of the things we see frequently on our ethics consult service, and you have to remember we get called on very difficult cases, are families who are themselves in crisis and frequently resistant and going through a lot of psychological and spiritual turmoil. And one of the things that contributes to this is the family is not on the same page with each other. So back to the conversation, which is not, of course, a single conversation, but a series of conversations. But the designation of a single person who will act on behalf of the patient, who very frequently cannot speak for themselves, is often a very, very helpful thing. Of course, this requires a lot of courage to act as someone's surrogate. But I think this is one of the ways in which the tension can get resolved if families have had at least a little processing. So at the time they reach the crisis, and every death is a crisis in that family, they are a little better prepared and therefore perhaps a little more receptive to the kinds of things that can be helpful to them.
Okay. So having that person that is the decision maker, the buck stops with that person, is the way to deal with that, you believe, early on?
Yolanda Holmes again. I think it's important when you talk about your decision maker, you have to make sure that you talk to families about getting someone to act as their decision maker that's going to truly do what they want. So often I see people make that decision in my practice, and they base that on my eldest child or my husband, and because of the bond there in those relationships, those people don't have the courage often to do what that person wants. And so when that patient, like Shari stated, gets to a place where they're not as cognitively functional, that individual really doesn't have the courage to go forth. And so they will, what I consider, dishonor their wishes and actually have that patient in a situation where they feel they're suffering. And so it's really important, I think, as we talk to families, I always tell my families, choose a person who will honor your wishes. I truly don't believe my husband would have the courage to honor my wishes. My niece, the love. He will have me in a situation that I wouldn't want to be. I will need to ask my niece to do that because she will say, now, Uncle Glenn, this is what. She will seriously. So as we talk about decision makers, it's not always your husband. It's not always your oldest son. Who amongst you? I had a patient one time, 2 daughters. The lady made her pastor because she said, you girls would never, ever honor my wishes. It was just so mind-boggling, but that's how her wishes got honored. And they honored their pastor because she was able to entrust him with that. So I think it's also important. We see that so often, that courage to do what a person wants is really, really important too.
No matter how much you talk about it, when it gets to be that time, is everybody prepared to stick with the plan? Yes, Dr. Goldman.
Bob Goldman. The flip side of that coin is one that I lived through a lot, and with your indulgence, a couple of minutes. Sitting with 3 children at 2 in the morning with a mother in a coma from a massive hemorrhage, and the answer I get is she would never talk about it. Now I have 4 victims, not 1. Our inability and unwillingness to confront the fact that this is something we will all face is in fact why medicine is what it is. Medicine didn't become this thing that treats people that don't want treatment. We're doing exactly what people ask of us. Keep us alive, don't let us die. We're afraid. Don't be surprised when we're not the answer. Sometimes we're not.
We've talked about some of the challenges to making end-of-life decisions. If there's one thing you could change, what would you like it to be that will help make this process of end-of-life decisions easier, better for families and medical providers? Is there one thing that you think would make a difference?
If there were one thing that I would like to see happen in this whole area, is that dying be recognized as a stage of life. Dying be recognized as a stage of life. I think that's what we've worked toward in trying to take care of our patients as they are dying. And I think this is a very, very important but very, very complex issue that I'm raising. It's not so easy to get people to see this.
One of the things that I'd like to see, especially in the inpatient population that I'd see, is more of an interdisciplinary team approach to caring for the patient, because sometimes it's a little disjointed. You know, the oncologist, the primary care doctor, the palliative care team, everyone coming together to support the family. So I think a stronger interdisciplinary team should be one of importance for us.
Is there anyone that is leading a charge to bring these different folks together? Where does it start? Because you've got willing participants here. Yes.
I'm Harriet Caro. I'm a member of the community, not involved in medical care, but the GIFT initiative was developed specifically to address what you just questioned, which is the need for a collaborative effort to occur in this community and frankly across this country so that we can remove the stigma associated with talking about death and dying. It is the one thing that unifies all of humanity, and so our reluctance to discuss these things with each other, with our providers, with our families, is something that can be addressed, and it really is something that should cross professional lines. And so this is something that I think that all of us as members of this community, as parents, as adult children of parents, need to agree to join hands together on and address.
A conversation like this would have been unimaginable a decade or so ago in Nashville. I'm involved with resident education at Vanderbilt, and in less than 10 years, palliative care has gone from just a very small consult service to the most popular chosen rotation of our residents. So I think that what we're seeing is actually a very positive thing. We're frustrated that we're not where we'd like to be, but we've really come a long way.
Next generation of doctors, huh? Okay. Anybody else, one central thing, yes, sir, that you would like to see change to make this better?
Rashad Fakhruddin. I'm an engineer, but I'm also involved with education and outreach at the Islamic Center of Nashville. Okay. Because death is such a strong, I guess death and dying has such a strong spiritual aspect in most faiths. I'd like to see a stronger partnership with the faith-based communities, with the medical profession, and I believe with this partnership, you'd be able to have such a stronger outreach, especially with the advanced directive. Many people don't know about it. This is the first I came to know about it, and I do have a will. And having a will is stressed, I know, in Islam and in many faiths, but there's a lot more that can be done in preparation by having a strong partnership with the faith-based communities.
Thank you for tuning in to our town hall meeting on end-of-life decisions. If you'd like to start a conversation with your loved ones about end-of-life decisions, our partner in this program, Alive Hospice, offers help and resources at thegiftinitiative.org. And we want to know what you think. Send us your comments at tv8@wnpt.org or by calling our viewer comment line at 615-259-9326. If you would like more information on this and future programs about aging in our community, go to wnpt.org/NPT reports. Thank you for watching.
This program is produced in partnership with Alive Hospice and the Gift Initiative of Alive Hospice, funded by Humana. Major funding for end-of-life decisions and NPT Reports Town Hall is provided by HealthSpring, lead sponsor of NPT's Senior Health Project. HealthSpring, where you get more from Medicare and more from life. The West End Home Foundation, supporting the care of seniors through many organizations in Middle Tennessee. By the Jeanette Travis Foundation, dedicated to improving the health and well-being of the Middle Tennessee community. The Corporation for Public Broadcasting, and by members of NPT. Thank you.